This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast. Hey, and welcome back to the Alert Medic 1 podcast. Tonight you've got myself, Cody, and Ken. We're going to be here talking to you about a case that broadens out into some clinical application of a some people would say new skill or a new intervention. Some places it's new, some places it's old. In Maryland, it is a new thing, and that new thing is double sequential external defibrillation, okay, or dual sequential external defibrillation. So we're going to kick it off with talking about a code that I ran a week ago that involved this intervention. So I'll kick it off with it was dispatched as a unconscious subject. My county that warrants an ALS2 response, so 2 paramedics are to be dispatched. I was on the medic unit that day, and I was going with a suppression piece. And on the way, they advised it was upgraded to cardiac arrest. And then no updates from that point forward. It's about 6-minute response to where we were going. But something that did stand out was the age, 37 years old. So, we're expecting some kind of update like now breathing, patients talking, because, how often do we run these young cardiac arrests? Peds, we don't run a whole lot. And then young adults. I wouldn't even say
usually turns them around, right?
Yeah. You usually find out this is an overdose or someone fainted or, the occasional hard sleeper.
And sorry I stepped on you there.
Nah, you're good. And so, we got no updates, and it's like, okay, this is a little bit more ominous. No updates, nothing about CPR in progress, nothing about anyone waking up. Get there. They direct us upstairs. My officer finds the family member doing bystander CPR in the hallway, and he is a very tall gentleman in a very narrow hallway. And so we immediately take over compressions in the best way that we can. Luckily, the middle of his chest was right by the bathroom door. So one guy went into the bathroom and was doing compressions. And our usual thing, get the pads on, just like everyone should be doing. And then a quick pause for an interpretation. What do we find? We find Defib. Okay, cool. Back on the chest, I'm going to charge up. In fact, I think this time I even charged before I did the rhythm interpretation. And shock. Okay, cool. Back on the chest. Doing our normal thing. Shock. Right back on the chest. 2 minutes of compression. So a rhythm check. We're not pausing and checking for a pulse. Nothing like that. We're going to keep on going. High performance CPR. We recognize that this hallway is not where we want to work this code. We've got a bedroom, about a 10-foot drag that we can move him and get in there and start working. So we decide after our next rhythm check, we're going to move into that bedroom. Yes, we're going to have a little bit longer than 10-second pause, but to make this code work and have a better chance overall, we've got to move them. So we hit that point, rhythm check again. What do you know? VFib. Shock him at 300. We move into the room, and now we're in the room. We're working. We've got 2 medics on scene, myself and one of my coworkers, Justin. We kind of start divvying things up. He has already told his crew from the suppression piece to grab his monitor as well. So that's something we've recently instituted with this new protocol, is that every code has 2 monitors on scene. Regardless of how it starts out, we're going to have 2 monitors on scene. Made sure that got into the room with us just to have it on standby. And we're working. Justin gets an IO, humeral head, like we always do. And then here comes another change. Someone says, hey, we got epi for you. And we both said, oh, hold up. We got to drop the amio. So something I've heard about, something you guys might want to think about in Maryland, or if you're doing this elsewhere and you're doing amio first, Another provider of my agency is putting his amnio with his syringe in the IO kit. There's some places that, your first epi or the lidocaine is sitting in the IO kit. He's putting the amnio. So it's a reminder, do this first. Because all of us are in this habit of drill, IO, or drill and epi. So we get all that drawn up. We get it in. Definitely, we're around our third shock. And what do you know? He's back in Defib again. So shock him at 360. And myself and Justin are like, okay, time for considering how we're going to put DSED pads on. So remember, in a traditional cardiac arrest, obviously we're going to be putting standard placement or whatever your jurisdiction dictates. As I found out in the following couple days, some places go A and P first. And that's how they work. And that's something we can talk about at the end of this. But we go with standard placement. So we've got our standard pads on. Now we got to figure out how we're going to put this A and P placement. So I had the compressor stop for about a second or two, slapped on the anterior pad. And in the life pack, don't quote me on what Zoll does, but on a life pack, that is the one that has the heart on it. Okay. So you're going to want to it's got a little picture of a heart on the bottom. And so slap that on the front. Okay. I've charged up my first monitor because those pads are placed. And what we're going to do is we're going to roll at the rhythm check, place the back pad, and put down on the Lucas backboard. Notice how I've said the Lucas has not been started. That's something you're not going to want to do if you're not doing A and P first. Manual compressions. It's going to be a little bit of a manpower issue possibly, and we discovered that as well. But it's what aids in doing this quickly and easily. So we come up to our rhythm check, and I have to charge my second monitor. Because remember, you can't charge a monitor without electrodes attached to the patient. So it's a safety feature. It's a good safety feature, I'd say. And what do you know? He's not in VFib. He's in PEA now. So we've got an organized rhythm, kind of irregular, but narrow complexes, no pulse. Okay, dump charges, back on the chest. We've got everything in place now, though. We are getting our Lucas top arm in place because now we've got all our pads placed. And, fast forward 2 minutes, my partner, Justin, he is getting the airway ready. Just how this was set up, he ended up doing all the skills. And I ran the monitors, just how this patient was set up in the room. Normally, we would split them. He would do IO or airway, and I'd do the other. But he was already up there. We got everything done. And we made sure to do salad. So we've talked about salad here before. He did the gross decon. So just sticking the Duchanan catheter down in there, doing a big old suction attempt before our shock. So we come up to our rhythm check. I'm telling him, hey, man, we're not going to be able to get the airway done right now. Just do your suction. We're going to do our rhythm interpretation, possibly shock, and then we'll do your tube during the next cycle. All good. Sweet. Come up to that check, back in VFib. And now we're going to do this skill that's brand new and, all the rage in Maryland, and charge up. We have both monitors charged up to 360 and shock 1 and shock 2. And here's where comes our first pitfall. Okay. So what I didn't know was going behind me, and luckily Justin was watching. And this is another thing I learned. Position so you can see the patient when you're doing these shocks, by the way. My back was to the patient. Justin was watching as along with the rest of the crew. Someone from my crew, and I'm not faulting them, I don't mean that makes it sound like a fault, went to put their hands back on the chest to continue compressions after the first shock because it's muscle memory. Justin was able to stop him. We delivered the second shock. And we're like, oh, crap, okay. That's something we need to pay attention to. That's right, 2 monitors being used. Code is continuing. Lucas is not on yet. And come up to our next rhythm check. By the way, got the tube during that time. Justin did a great job. We were able to pass bougie, pass tube, secured it, good airway. I think his initial end title was in like the 50s or 60s and then kind of plateaued into the 30s and 40s. That's a pretty good indicator for those that don't know that maybe ROSC is going to be coming. We're going to have something here soon. Come up to our 5th shock. Okay, 5th rhythm check, or this is our 6th rhythm check, 5th shock possibly. Back in VFib, charge both. Shock 1, shock 2. Once again, another pitfall happens behind me. Another person that was outside of the room during the code had come into the room and was helping move the patient for Lucas placement and went to grab the arms between shock 1 and 2. Justin stopped them, and they're like, oh, crap. So this is 2 near misses. And I'll talk about why that's important and also why it's important that we practice this, as Cody brought up prior to the episode, that this requires practice. This is not just your run-of-the-mill codes, okay? So we're working through this. Next rhythm check, come up to it, shock, another double sequential, no pitfalls, no near misses. One goes off cleanly. And then we get to what's now our 7th rhythm check, and our patient's in PEA. We have no pulses, so we dump charges, continue compressions. In my jurisdiction, the EMS supervisors carry a ultrasound probe, and so I said, hey, let's get that ultrasound probe out. We're going to do a carotid assessment. That's the one thing we use ultrasound for in my jurisdiction. And so he got it set up. He's watching the carotid during compressions via Lucas. He's got a good look. Charge up monitors, come up to a rhythm check, pause, and we've got great carotid flow. Okay, cool. We don't have pulses, though. Okay, so this is a pseudo PEA is what we're going to call it. It is, but it's so faint that they're so hypotensive and in such a profound shocky state, we cannot feel a radial or a carotid pulse. But there's carotid flow. So obviously there is something moving blood to the brain. So we're continuing compressions at this point. That's what we are doing within our jurisdiction. Hopefully everyone else is as well if you're doing this. And we initiate an epi drip. So now, we're getting into the weeds of this mega code. Okay, that's what this is, essentially. This is the mega code that you run in class. Okay. And we've got the epi drip going. Within about 4 or 6 minutes, we get to rhythm check, and we have pulses back. So now we've got ROSC. And I'm going to take a quick pause and open it up to Cody and Ken and see if they have any questions or comments or anything they want to ask about what has led up to this point already.
One of the first things I caught in the way you told the story is, when you said Justin was getting all the skills in, it sounds like you're settling into your DPO role pretty good. The old bull engineer there, not having to do anything. No, all joking aside, I think you hit some really good salient points there. Kind of going back to what we talked about before the episode. Process changes create new challenges for us. It's not, right, as you guys learned, it's not as simple to put a new tool or a new thought into practice on the first day. You have to, in the military, we do these things. And you remember this too, Josh. You do rock drills, right? Rehearsal of concepts, and each stage of your operation or each stage of your mission or whatever, you do a tabletop essentially exercise of how it's done, so that you don't get shocked when you get on the mission and you see these problems for the first time, or you get out into the
no pun intended.
Yeah. I didn't even see that. Oh man, didn't even see that coming. But so you don't get surprised when you encounter these new challenges. One question that I have, I guess, is what are you guys doing to alleviate these new manpower challenges that you might have uncovered? Did you find that you need a couple more hands with this style of resuscitation, or you have too many, or what?
So I will say this code, because of it being in our state, from our station, and in our first due, we only had 6 people to start. A lot of other places in the county, when they encounter this, they're going to have about 10 people, because of how our ALS resources and transport resources are distributed across the county. But we did recognize that. The officer on the suppression piece recognized, like, hey, we're doing CPR for a little bit longer. We've got less bodies on scene, and this is starting to look like it's going to be a complex, quote unquote, extrication from the house. not really extrication, but just movement out. And he decided he's going to request the other suppression piece from my station and use them as manpower, which brings a third paramedic to the scene, which does help out with somewhat, but a lot of the ALS stuff was done by the time he showed up. But yes, it was something that we recognized and realized it's like, hey, we need some more people. And
Yeah.
that's something to hit on that we can talk about a little bit later too. There's going to be jurisdictions in this state, there's jurisdictions around the nation that getting that additional manpower is going to be a struggle. So
Yeah.
you might have to figure out what to do with what you have there to the best of your ability. I know in the state we've been doing high performance CPR for at least 7-8 years. Ken, I'm trying to think of when that protocol came out. I think I wasn't even back in the state yet. I think I was still in Texas. Does that 7-8 years sound right, Ken?
Yeah, it's been a while. Yeah.
So we're used to like having to coach people to swap out and understanding roles, and even then sometimes those 2 minutes turn into 4 or 6 per compressor. But we're really going to need to pay attention to that, and then pay attention to how to get these patients out of the house, because as you're about to find out, this was not easy. So Ken, do you got anything? Okay, cool.
I was gonna add one more thing before you got into it, Josh, of that pseudo PEA stuff. That's not something we hear about a whole lot. I first, I mean, that it's one, you need ultrasound to be able to find it, or to be able to go, okay, this is actually PEA or pseudo. I'm sorry, this is a pseudo PEA. I think one of the other terms for it is called lost low output state, where the heart,
I think I've heard that.
the heart doesn't have enough pump, and the system doesn't have enough juice in it yet to fill completely. But the heart is moving, but there's no forward flow, or not a lot of forward flow from it, and so you can't palpate a pulse. And when I think about that now, I think back to, man, how many codes did back in the day did we maybe call a little early, or granted there was probably no coming back.
We didn't know what we didn't know. As Moose likes to say, we didn't know what he didn't know.
Didn't know what we didn't know. I like that.
And I said the same thing to my supervisor actually at the end. I'm like, 3-4 years ago, that guy, not to allude to what happens, but that guy would have been left on the carpet.
Yeah.
It's great to see these innovations, that we are turning the corner on these patients. And now, granted, that's a rabbit hole. I won't get into that right now. So we'll get into this next part. And this next part is important. It's not protocol driven. Actually, no. I think it might be. Don't quote me on this. I'm having a little blank moment. So we've called ROSC. We've got pulses. We actually start to have some spontaneous respiration. We've got good end tidal. He's got a irregular rhythm. It's sinus. I think it started junctional, went to sinus, that had some PACs, then regulated out to just a regular sinus tach to a high normal sinus. And blood pressure, I want to say the initial one was maybe 80 or 90 systolic, kept going with the epi drip. And so this is where, like I said, I can't remember if it's protocol driven, so tell me if I'm wrong, or tell me if it is, but a ROSC timeout. Okay. So yeah. Okay. I'm getting blank stares / not shaking of heads. That is not in protocol. So something that you guys, if you're not doing this in the state and or elsewhere, when you get ROSC, this isn't the moment where you're like, okay, throw everything together, throw them in the Reeves or the backboard or the sheet or whatever you're going to use to get out of the house, and let's get out of here as quickly as humanly possible. No. What we want to do is we want to take a moment and slow down. We want to evaluate all of our vitals. This is when we're going to get a blood pressure, a SpO2, make sure our end tidal is good. Look at our rhythm, get a 12 lead, which, hey, by the way, we're now using double sequential. So we got a whole lot of pads on the chest. What are we going to do? My suggestion, and this is definitely this is a Josh suggestion. This is not, any jurisdiction saying this. Remove and move pads as needed. Okay. But keep one set of complete pads on the patient in case they do rearrest. Okay. But we do need to get that 12 lead. So move things around as needed and make it work. I'm not going to tell you exactly how to do it because every patient is a little different. This guy looked like a relatively fit individual. So he had a broad chest. He wasn't a tiny pigeon chest of an elderly patient or, a very obese patient where everything was very spread out. He was like right in the middle ground. So we had to move pads a little bit, but we kept at least one set on. And I give credit to Justin. Justin, I work with him almost every 3 days for the past 6 years. And we teach together. We make CE together. So like we work very well together. And he caught me. He was like, "Hey, we need to slow down. We're in the ROSC moment. Let's temper it down and let's get this stuff done." What else do we do during ROSC timeouts or the ROSC period, bundle of care, whatever you want to label it? So 12 lead vitals. If you need secondary access, this is the time to do it. So you've got a patient that likely has a decent blood pressure that you can now get an IV. Take that time to find that secondary access, because maybe during movement out of the house or into the unit or something, or the patient wakes up and throws his arms. Now that humeral head IO is possibly no good. It is one of the downsides of the humeral head is that if the patient becomes conscious, they have a chance of taking out that access site. And then if you have not done your advanced airway by this point, go ahead and do your advanced airway, whether that's ET tube via preferably VL, but if, whatever reason, DL or an SGA, whatever your choice is, whatever your agency uses, King or iGel. Those are the two most common right now. If you guys are still using combi tubes, reach out to your supplier and figure out something, please. We already had our advanced airway. We didn't have to worry about that. Secondary access, we ended up doing outside, but we took our time. We also made sure to talk with the two suppression crews there. Like, okay, how are we getting them out? We'd already gotten the Reeves up there early. We knew that's what we're going to use. We found that Reeves and Lucas devices work best instead of Lucas devices and backboards. I know back in the day, for all of us, we were probably moving codes out of the house and backboards because it made it easy for compressions, plain and simple. Well, plastic on plastic of the Lucas backboard and the backboard slide all over the place.
It might as well be ice.
It's not good. It's not good for going out the house.
No.
Okay. And the Reeves comes with built-in straps. Easy. And or even if you guys don't have Reeves, Fat Man Sex. Or Mega Movers. Sorry, that is the.
You have to have perfect diction to get that out on a microphone and it not sound nasty. I was like, wait.
Mega Movers for the PC term, and so figure that all out. And the suppression crews are figuring out how are we going to move down the stairs. We're on the second floor. It's a tight hallway. It's a tight set of stairs with a 180-degree turn with a guy that's, I'm going to say, at best 6'5". This is going to be tough. Ken, I know you are probably having some little PTSD nightmares coming back and moving people out of row homes and those rickety, narrow, mid-level set stairs. Oh, God, I did one in private transport, and I thank God I didn't work for Baltimore City after going up and down those stairs with a stair chair. Oh, man. So, and that's that time. Figure it out. And so we package him up, and he's got all the stuff. We figured out that we were going to take a gamble on his taking off a monitor. Basically, we left one set of pads, and just because of moving down the stairs, moving two monitors, keeping everything connected, cables, we already had 12 lead, 4 lead, SpO2, blood pressure, an epi drip, the Lucas. Pads, tube, BVM, tons of things. Okay. And in my agency, it's only about to get bigger when our supervisors have vents. So how do we get him downstairs? We had to, at times, stand him up basically in the Reeves to get around the corners and get down the stairs. So this is where we need to kind of champion an age-old thing that we've done in EMS. Reassess. Get down to the bottom of the stairs, figure out if you still have pulses, figure out that everything's still attached and needs to be attached. Things are still running. Like as I'm going down the stairs, I hear the pump screen making sounds as it's getting touched by different things on the patient and the Reeves. Well, somehow and all that, it went into the dosing screen. Luckily, it didn't change the dosing, but it's one of those things. You get down at the bottom of the stairs, you got to reassess and make that move out to the unit. And from that point, it all ran pretty well. Honestly, we moved out of the house, got us to the unit. I took one EMT to bag. I took the second, Justin as the second medic, and off we went to the hospital. Did a consult. It went much better than the last code I talked about with Mike, where the handoff wasn't great. Handoff went very well with this patient, and the patient ended up getting sent up to the ICU. The 12 lead, by the way, had some some depression in 4, 5, and 6, AVR elevation with maybe other depression. We're not totally sure. It wasn't the cleanest 12 lead, but he ended up not having any ischemic activity. As far as I know, he went to the ICU, and the best guess that the hospital had was rhabdo, and they found polycystic kidney disease. So what drops a 37-year-old into cardiac arrest from almost no activity beforehand, not appearing sick or injured prior to that? I don't know. But this is the end of the call, so looking back on it, we talked about 2 of the pitfalls and the near misses and what that needs to involve, as Cody put a rock drill of sorts to figure out ahead of time how we're going to run these. Cody, Ken, what do you got?
I was going to let Ken go first.
No, I think it sounds like a really good call. Sounds like everything went well and you got the outcome you wanted, and there's some good takeaway points there about positioning people and making sure that everybody is having a clear line of sight for all the activities involved, because there were some near serious misses there.
Yeah.
So that's not good. So it is something we should be drilling and training. And I think the real key here is that this isn't an extraordinary call. This is a new normal. This is what we need to be prepared for on every single cardiac arrest. It's no longer like something one jurisdiction is doing or somebody's trialing, or like, this is a science. This is what we need to be ready to do on every call. So that's my biggest takeaway.
Yeah, it's something I've said numerous times when we talk about cardiac arrest on here. Expect the ROSC. Expect the VFib. Expect the VTAC. Don't, I know the numbers. So I was talking beforehand with, before we started recording, my jurisdiction last year had 94 cardiac arrests start in VFib or VTAC, or an unknown shockable rhythm. And then 400 PEA asystole. I don't know. We had a total of just under 800 cardiac arrests jurisdiction wide last year.
I love that. I love that.
And so 94 started that way. I can't tell you if any transitioned, but this is, while the VFib arrest is not as common, that doesn't mean that your PEA asystole arrest doesn't turn into VFib. I had that a month prior, and I talked to Mike about that call. So, and that patient ended up getting vector shock or vector chain shocks, because that's what we were doing at the time. Now we've moved to double sequential since the protocol change, and that guy would have gotten double sequential had it been a month later. And be ready for changes. Be ready for dynamic scenarios. This is not, just go in for 30 minutes and then terminate and go home. Be ready for things to change. Even on your nursing home cardiac arrest, it happens. And you know what? Mm-hmm. Even when we look at it, we're like, this patient, they have all these comorbidities. They're 90 years old. They should not be a full code. But when it's presented and it happens, it's our job to treat it appropriately and correctly. Yep. So something I wanted to talk about with the pitfalls that happened, or the near misses. So the people that were on this code work together every 3 days. They're in the same station. There's 16 people on my shift. There was only one person there that was from another shift, but he's on B shift at that station. So he is just as inundated with these type of calls as we are on C shift. And we still, as a team that works together every day, had these near misses. And so when you're working in areas where cardiac arrests get, 3-4 different fire companies or EMS companies that show up and run this code, or they're coming from all over the place, imagine what could happen then, you know? And this can happen in my jurisdiction. You know, it's very easy elsewhere in my jurisdiction to have a transport unit from one station and 2 ALS resources from 2 different stations that don't see each other all the time, you know? And so this is where, if you're in one of these type of agencies, you need to get out there and train together and figure out some kind of training or rock drill, or just talk about it. The hands-on is pretty vital in my opinion, but if you at least talk about it and say, hey, there's this new thing, this is how we're going to do it, this is how it's going to look, this is what we're going to say, that is vital to this thing, because it not only benefits the patient but benefits the crews, that they don't accidentally get shocked. So
Yeah, I think. Well, I was going to say it highlights a big thing that I don't think we talk about enough, and that's protocol versus process. And you could extrapolate this out to stuff like RSI. Like there's a way, and especially in the state, there's a way that the protocol is written, but there's a process to it that you can hit all the boxes, you can hit all the high points of the protocol, but the process, the way in which you execute the protocol, is much more fluid and what's much more dynamic, and it is situationally and contextually appropriate and accurate. If that makes any sense at all. The way you go about implementing the protocol is the process. And I think a lot of times we are so wrapped up, not we, and not every jurisdiction and not every provider, but there are some folks that we're super wrapped up in the protocol is written this way, step by step, paint by numbers, and there we go, we've got it. But it's super important to have your processes locked in, locked down, and down to the, have them memorized. That's the word I was going to go with. Have them memorized down to the T. Checklist if you need them. I think there's a little plug for checklist in there.
It comes down to something we've talked about before, which is don't be a protocol robot, right? You have to adapt what's in writing to what is in front of you at the time at the scene. There's nothing that says if I've got a status asthmatic that I can't start a neb while my partner's given a shot of epi, right? Now, that's not what the protocol says to do. But if you know what bad asthma looks like, and you know that this person is going down the tubes, there is absolutely no reason that you can't do 2 things simultaneously. Just like in the cardiac arrest. Of course, we don't want to take the pads off, but sometimes you have to move people. And the monitor wires are only so long, right? So what are you going to do? We don't want to stop bagging people, but we can't necessarily put somebody in a man sack or in a reeve sleeve and move them down a set of stairs and continue to bag them. Like, it's not humanly possible sometimes. So I think it is important to contextualize those sorts of problems and really look at that. You may not be able to, you have pumps. That's great. But in jurisdictions that don't have pumps, there will be an issue keeping that epi drip running while you're moving down the stairs, right? You may not be able to do that. So just little things like that to think about while Cody gets eaten by a dog.
No, like that part about manual drips is super important, because this is, in Maryland, we're a unique organization. I'll say that that we're one of the few that uses drips in the 911 setting, and probably pumps, not drips, pumps in the 911 setting. That's where that reassessment comes into play big time. Like, hey, we're getting back down to the downstairs. We've stopped this drip while we were going downstairs because we cannot monitor it, and we don't want to be giving too much. And heads up, just because when you're upstairs and you were dripping at 1 drop a second doesn't mean during your movement it was 1 drop a second the whole time. I vividly remember my last epi drip before we got the pumps. I watched it swinging, doing 3, 4, 1, 5. Like, it was all over the place. And it's just, we can't, the movement may do that, but we also can't really monitor it very easily when it's trapped up in this patient that's in a Reeves or a Mega Mover or whatever you're using to get them out. You usually don't get a good visualization of it. And You got to figure out risk benefit on this patient. Do we stop it? Do we keep it going? Do we, hey, maybe we take this ROSC time and we extend it out a little bit more and get a couple more minutes of epi on board and get them in maybe a slightly hypertensive state so that we have a protective barrier of that movement downstairs where, okay, we get back downstairs. Okay, they're at 100 systolic now. Start the epi back up. Now we can watch it. Now we can monitor it. Dynamic care, not static, not protocol driven, clinician level care or clinical thinking. The protocol is not going to tell you, okay, when you've got ROSC, you're going to want to do this, and this order at this time. And if you don't have this, then you must do this. And by the way, when you get midway down the stairs, you should stop and reassess and blah, 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 blah. No, that's all clinical thought. That is you deciding what is best for the patient and what is going to work for you and your team on scene. Okay. Cody and I kind of talked about this the other day with measured aggressiveness. You got to figure out what you can manage in the time. Some places, this may call for push dose pressors, and that is a little bit more manageable in a move. If you got manual drips, but you got to figure out what works for you.
Yeah, and during those timeouts and during those and I know that I got this hammered into me. Some of the NCOs I had early on in my military career was, man, every time you move, every time you stop, every time something changes, you recheck all of your interventions again and re-secure them. There's what we do in the house to get the IO in, and then you get 5-6 minutes down the road a little bit, and you're like, oh man, we haven't secured that yet. And so you go back and those timeouts are the times where you look at your intervention, not just look at them, but okay, I need to put a little bit more mustard, some more tape, some more, or actually secure the thing. I can't tell you how many times when I was flying, there's the stuff that you do at the bedside, and you kind of stick a pump wherever it's going to be, and you're like, okay, when I get in the aircraft, I'm going to do X, Y, or Z. And if you don't take a quick pre-departure timeout and look at your pumps and make sure some of them actually didn't accidentally get knocked out of the infusion phase, and you're just kind of sitting in a menu waiting on permission, so you haven't been infusing these medications for XYZ amount of time. You have to be real deliberate with these timeouts, not just go, hey, is everything good? You need to take the time to do that. Be very, very diligent with it. And I kind of like this idea of de-escalating things so that I can re-escalate care later. Like, oh yeah, you had to take a monitor off so that you can move the patient, or you can do a 12 lead. And the cool thing about DSD is that, yeah, you can remove a set of pads and you still have another set there to do standard defibrillation. Again, this goes back to process of, oh shit, these defib real quick, bam, hit them, and then set back up for DSD again later. Again, you have to rock these out. You have to plan them and have these processes down pat so that it works as seamlessly as we want it to.
Yeah, and by the way, on the keeping of pads on, if you have to disconnect one monitor, Josh, suggest you disconnect the standard placement pads monitor. So the Maryland protocol is, if you can't do double sequential, you do vector change. So that's that AP placement for a single set of pads. So if you got to pick one, keep the vector change pads attached to a monitor. So you have a better chance of, if they do rearrest, of converting compared to your standard placement. Ken?
Yeah, I was going to actually say the same thing. For like a logistical reason, I would keep the anterior posterior pads, because it saves you from having to turn that patient again, and all that kind of stuff. The other thing I wanted to bring up when we were talking about being a protocol robot, and then we were talking about making sure to follow the protocol, but use good clinical judgment and critical thinking, is that we had a scenario recently in class where it was post cardiac arrest, ROSC, all that good kind of stuff. And the students were jumping right to doing a 12 lead. Well, of course, we want to get a 12 lead, but the blood pressure was like 70/40. So this is not a hemodynamically stable person. So we need that 12 lead. It's very important, but we need to make sure this person is perfusing first.
Yeah, 12 leads don't save lives.
Nope.
In the immediate, the perfusion saves lives.
Yep.
Not only that, I don't have a time frame that I can give you on this, but there is a lot of discussion that post cardiac arrest 12 lead during ROSC should probably be on the higher end of like 10, maybe 15 minutes post ROSC, because you're actually going to see a lot of the cardiac ischemia from the CPR still present. Yeah. So, like I said, I don't have a time frame. I know there are some studies out there about it. Maybe I can find them before this gets published, and we can throw them up there with it. But there definitely is some relation to early 12 lead post ROSC showing like what is an ischemic event turning out to not be an ischemic event in the end. So.
Yeah, because you do have a lot of that kind of stuff where you worry about the rate related ischemia, and then the fact that the heart's been hypoxic for the last 20 minutes, and we have that maybe ischemia related to that. So we need to get back to a nice baseline before we get a 12 lead is probably wise advice.
Yes. Before we don't say it, I just want to hit that there is a part of this protocol that really only applies to, I'm going to say, mainly one jurisdiction in this state right now, and that's the eCPR portion of the protocol. And the only reason I say that is because you have to be within 15 minutes of an eCPR facility, and it's Hopkins and University of Maryland
Correct.
State right now.
Yeah.
So this primarily affects Baltimore City. There are probably parts of Baltimore County that may be part of this, and Anne Arundel for those that are in Maryland. I know other places around the nation have eCPR that's getting kind of stood up along with this whole double sequential, ESMA law, a whole bunch of different other things being thrown into this algorithm. So if you do work in Baltimore City and you're listening, remember there's the eCPR portion of this protocol. And while there is a suggestion of urgency off the scene to the eCPR facility, don't forget to do these important things that keep the patient stabilized during your transport. Okay. That's really it. I don't think there's anything else on my mind. Oh, real quick. That's right. We did elicit a bunch of information from the followers on the Instagram page. Thank you once again. I know we posted saying thank you for the information, but once again, thank you to everyone that responded. That was great information. I love seeing the protocols being shared. Had someone reach out from Wake that's been doing it for almost 10 years now. And a bunch of other jurisdictions doing different things. Something to think about. And I'm not saying that, if your agency does standard placement first, continue doing that. That is your local guidance and protocols. But there are places that are doing A and P first, because then they can easily do the Lucas and then attach the standard placement pads without interrupting any compressions, and you can charge leading up to that shock. Because heads up, a LifePak 15 on a fresh battery charging at 360 is approximately 12 to 15 seconds of charge time. So that is one, busting your 10-second rhythm check time, and that's not really what we want to shoot for. So we want to try and have those things in place and done. But yeah, there's some great work being done around the nation with this. I think this is going to definitely become the norm. It is. I won't say maybe it's in its infancy around the nation, but it's definitely going to become the norm. I think with a lot of protocols. Dare say I throw out there that the AHA may include it in their algorithm someday.
Dare you say?
Does someone have to pay them the right amount of money from the DSED side of the house to get this in there? But you know, we'll see. We'll see. But it's great to see. I know something I took away, and I kind of hinted at it, is that this patient at some point in my past would have been left on the carpet at that house. Okay. And
Yep.
in all of our pasts here,
Yep.
that patient would have been terminated on scene or left on scene. For those that don't have ultrasound, I urge you to think about if you have a young patient, actually, regardless of the age of the patient, but this patient in specific, young patient that has an instance of VFib or a change in rhythm during your cardiac arrest, to VFib, VTAC, a PEA, or back to a VFib, anything like that, just transport them. I know we're in EMS, we push for the termination on scene nowadays, and that is becoming the norm. But if the heart is trying to do something, it is trying to change, let's give it a shot. Let's give it that definitive treatment in the ER where they can, employ maybe a couple other tools to figure out, is this fruitless or not, and then terminate. Just like with this patient. He started VFib, then went to PEA. If we didn't have ultrasound, we would have just kept on working and working and working.
Mm-hmm.
In my mind, I'm still transporting this guy. There's lots of indicators that this could be a save in the end. So,
Yeah.
and then it ties into, we've come a long way in cardiac arrest care. And I think you're going to see more and more come in the future. And we're going to see more and more positive results as things get added. I know anecdotally, the three of us have seen way more ROSCs in the past 5 years than we did in, the 10 years prior to that.
Absolutely.
Yeah.
And that's because of high performance CPR. That's because of early shocks leading up to rhythm checks, charging 10 seconds or less on downtime, all these things.
Mm-hmm.
So keep doing these things that are proven to be right, proven to work, and we're going to see more and more good coming from this. I don't really have much else, guys. If you guys have any closing comments about this DSED and the call and any other topics that came up from it?
Yeah,
Not
I would
really.
just highlight again. I'd highlight again that it's not enough to watch a video and do an in-service. When you're implementing especially something like this, when implementing anything new, it's not enough to do an in-service, and it's not enough to watch video. This is something that your organization needs to have a very intentional focus on for a couple of weeks until everybody has the process down pat, no matter what it is you're implementing, but especially something like that.
Awesome. Well, if we have nothing else, Ken, you want to close it out?
Sure. All right. Thank you, everybody, for listening and watching Alert Medic 1. We appreciate your time. Please follow us on Instagram. Check us out on Facebook. Like and subscribe, whatever the viewing or listening option of your choice is. We're happy to have you as listeners and viewers. And the last thing I'll say is good night, world, or good morning, world, wherever you are, whatever time, whenever you are. We appreciate you. Have a good day.
Okay. Be safe, guys.
Read the dirt.